diseases. So all the infections, they behaved just like the way Dr. Tanu Singhal, as infectious disease expert, has predicted. Introducing Dr. Tanu Singhal, she has done her MD Pediatrics from All India Institute of Medical Sciences and her infectious disease MSc from London School of Tropical Medicine. She has joined Hinduja Hospital as a consultant pediatrician and infectious disease expert from 2002 to 2008, and from 2009, she had been associated with Kokilabean Ambani Hospital since its inception as infectious disease expert, and also looking after the Department of Maternal and Child Health, as well as travel. She has got 2 books, 20 publications, 20 book chapters, 65 publications, and she has been an expert to advisor to the ICMR on infectious disease, antimicrobial stewardship, on tuberculosis control program, and many awards. As an undergraduate, she has been the topper of first, second, and all professionals from Savai Medical College, Jaipur, and has received the Best Student PG Award from AIMS also, and Best Student Award from Udaipur also. So I invite Dr. Tanu Singhal to enlighten us on this new menace of monkeypox. What is the virus? We have many questions. What is the disease and how it spreads? Dr. Tanu Singhal, please.
Thank you so much. Thank you for inviting me. And I, Dr. Sangeeta, I remember, when I had joined as a postgraduate at Nancy first, I had met ma'am. So I'm happy to see you all.
Sorry to interrupt you, ma'am. I just welcome Dr. Alka Agrawal, who is the AOP UP president, and I want ma'am to have some welcome notes regarding this topic. Ma'am, please, ma'am. I just want to have some welcome notes of you.
Thank you so much. Thank you so much, Dr. Amit, and Dr. Indu Waklu, ma'am, Dr. Sangeeta Yadav, President, Secretary, President Dr. Abhishek, Secretary Dr. Amit, from Lucknow Academy of Pediatrics. It's a privilege and honor to have Dr. Tanu Singhal of first status to be presenting on such a pertinent topic, which has been in news for some time now. On monkeypox, I think it will be a clarification of certain myths also, and we'll be learning a lot of facts also. I just take this opportunity to thank all my members, all my EB members, as well as all the dignitaries from UP State, who have actually been working hard throughout this year. And I want to tell you that this has been one of the very happening years in which every Sunday or every weekend there are activities happening in almost all districts, especially those districts which were not participative in the past years. So, and it's now been actually all physical meetings, so the number of online meetings has decreased. So it's really a pleasure and honor to have one of such meetings, because online meetings can reach the state far and wide. So thank you, Dr. Tanu, for accepting the invitation. Thank you, Lucknow Academy of Pediatrics. And thank you, Dr. Ajay and Dr. Sanjay Niranjan, without whom these activities wouldn't have been possible. Thank you very much. Over to Dr. Amit.
Thank you, ma'am. Thank you. So now, without taking much of time, I will ask Dr. Tanu Singhal, ma'am, please to be introduced. Ma'am, please. Ajay sir, ma'am ko.
Can you see my screen?
Yes, ma'am. Yeah, it's there. Okay, now, ma'am. Yes, ma'am.
Yeah, just 1 minute. Yes. So thank you so much for inviting me to talk about this new topic. And I hope, this is not going to be like COVID, because I remember almost 2.5 years back, I had given one update on COVID. And at that time, I had no realization that COVID is going to be what it has become. I think this is going to be lesser. That's my gut feeling. So we're just, going to talk a little bit about monkeypox now. We all know, we've all heard about smallpox. And I remember that when I was a small child and I used to go by train, I would often see on the, alongside the houses, it would be written that anybody who kind of pays money, who reports a case of smallpox will be given a reward. That was my earliest recollection about smallpox. And many of us also have those scars of the smallpox vaccination. And monkeypox is actually a virus which also belongs to the same family, which is the orthopox virus genus of the Poxviridae family. And its other cousins are this smallpox virus, which is now eradicated, vaccinia, which is actually the smallpox vaccine virus, cowpox, then there's something called rabbit pox also, and etc. So they are all related to each other. Now, the reason why it was called monkeypox was that it was first discovered in research monkeys in Denmark. And now actually the WHO is probably thinking of changing the name of this virus because it believes it is stigmatizing to the monkeys, because the monkeys don't have really a lot to do with this virus. And then the first human case was reported in this Democratic Republic of Congo. I'll show you the Africa map in a minute, but basically it's in Central Africa in 1970. And since then, this virus has actually become endemic in Central Africa and in Western Africa. So there are two main clades of the virus. One is the Central African clade and the West African clade, which is clade 2. And both these viruses are actually different because the clade 1 virus is more severe as compared to the clade 2 virus. And these viruses have been causing small outbreaks in Africa since the past 30 to 40 years. Now, this virus is different from smallpox because it has an animal reservoir, because it was first discovered in animals only. And most of the reservoirs are monkeys, some other primates, squirrels, rabbits, and some other small animals. And it can spread from humans to animals, and from animals to humans, and it can also spread from humans to humans. And usually a very close contact is needed for transmission of monkeypox. So in that way, it is different from COVID, because in COVID, you can get, infected even by a casual exposure, whereas in monkeypox, you have to be living with that person or in close contact with that person for some time before you get infected. And infection can be by inhalation of the infected droplets, also by contact, and also through contaminated fomites, because the virus can actually remain on the surfaces for quite a bit of time. But it is not as transmissible as smallpox, because in smallpox, what happened is that, when there was one family member who was infected, 30 to 80% of the other family members would get infected. But in monkeypox, the secondary attack rate in families is not very high. Now, there is this concept of sexual transmission also, but people really don't know whether the virus is transmitted actually sexually, or is it because of the close contact which happens during sexual intercourse. And as we will see later, in the current outbreak, most of the infections have happened in men who have sex with men. Vertical transmission of monkeypox has been reported, and pregnant women can actually pass on the virus to the fetus and the newborn, and can result in serious consequences. So you can see that how the virus is actually different from smallpox, and it is also, different from quite different from COVID-19, which we've been grappling with till now. Now, in Africa, which is really the place where this virus is a problem, you are basically 10 countries are endemic, and the Democratic Republic of Congo, which was earlier called Zaire, is the worst affected. And what has happened is that through the past 40 to 50 years, beginning 1970, the number of cases has actually gone up. While in the earlier part of the 1970s and 80s, it was mainly children who were infected. As time has passed, it's basically young adults who are infected. And the virus, actually the case fatality, as I said, depends on the clade of the virus. So in the clade 1, which is in the central part of Africa, the case fatality rate was 10%, whereas with clade 2, which is seen in Nigeria, etc., the case fatality rate is 3%. Also, another important thing which happened was that initially most of the deaths were in children, and now children contribute to less percentage of the deaths. The other very important fact is that previous smallpox vaccination protects to a certain extent against monkeypox. So even if these people who have been previously vaccinated with smallpox, they get monkeypox, it is of lesser severity and deaths are less common. So Now people wonder that why has the virus actually increased in Africa? And the reason is that there is waning immunity since smallpox vaccination was stopped in 1980, because we all know that once smallpox was eradicated, smallpox vaccination was stopped, so the herd immunity has gone down. And also because in Africa there is encroachment over the forests and there is closer contact between humans and animals, which has led to the spread of the disease. And remember, this was one of the main reasons why there was spread of Ebola as well in 2014 and 2015. And in this year as well, there have been about 1,500 cases in Africa and 60 deaths. And as I shall tell you later, it's basically the disease which has happened in Africa which has caused deaths, not the disease which has happened outside Africa. So this is like what the monkeypox graph looked like in between 1970 to 1979, that you had almost just 50 cases in Africa. Whereas if you look at the current graph, which is between 2010 to 2019, you find that Democratic Republic of Congo has more than 18,000 cases. So clearly there has been an increase in cases in Africa. And while if you actually do a review on PubMed, you will find that since 2010, there are more and more papers on monkeypox which are appearing and which are saying that, look, this virus is increasing in Africa, we have to be careful. But when anything happens in Africa, it does not catch the world's attention. It happened also with Ebola, that only when actually Ebola spread to US and Europe that people actually came to know about it. So this has been increasing in Africa, but nobody has really paid any attention. But there have been cases which have been reported outside Africa also, because in 2003 in USA, there were actually 60 patients who got infected. And they got infected from some prairie dogs who were in turn infected from exotic animals from Ghana. So we know that all these current emerging diseases in humans are all zoonosis. That is, they are coming from animals. And we know COVID-19 was also a zoonosis because it was earlier in bats and then it stepped into humans. And so also it's monkeypox. And this time the people were aged between 4 to 63 years. And also 21% of them had received smallpox vaccination. This is important to know because many of us in India, especially the ones who were born before 1980, feel that if we have received smallpox vaccination, we are completely protected. The answer is no, you are partially protected, but not completely protected. And 26% of these patients needed hospitalization. One child developed encephalitis, but nobody died. And after 2003, there have been a few cases between 2018 to 2021 in UK, USA, Israel, and Singapore. And all these cases were basically in people who had traveled to Africa and then who had come back. So, although the cases were increasing in Africa and there were some cases outside Africa as well, people were not really bothered. And then came this current outbreak, which has caught the attention of the world. So the first case was reported in May 6 from UK in a patient who had traveled to Nigeria. And since then, there has been a steady increase in cases. And there are many cases who don't have a travel history to Africa. So that means there is human-to-human transmission happening even in all these countries. And as of now, there are more than 18,000 cases from 75 countries and all 6 WHO regions. And the maximum number of cases are in Spain, USA, Germany, UK, and Northern Ireland. But surprisingly, there has been no death due to monkeypox outside Africa. And one of the reasons is that the clade, which is responsible for the outbreak outside Africa, is actually a clade 2 virus. And this virus is actually similar to the virus which caused the disease in 2021 in an USA national who had returned from Nigeria. So it is believed that this outbreak which has currently happened in the world is actually coming from Nigeria and not from Central Africa. And the WHO declared it as a public health emergency of international concern on 23rd July 2022. I think this time the WHO declared it early because they had faced a lot of criticism because they didn't declare COVID-19 as an emergency early enough to stop transmission. Now, as far as the situation in India is concerned, there have been only 4 cases. 3 have been in Kerala in young males returning from the Middle East, and 1 is from a male in Delhi who didn't have any history of foreign travel. But what is interesting to know, which I read in the newspapers, is that the strain which is responsible for the Indian cases is actually different from the strain which is responsible for cases in Europe and the USA, whereas that is clade 2 lineage B1. In India, it is lineage A2. So we really don't know whether there is a distinct cluster from which Indians have got infected, or these cases were happening in India and now they have come to attention because of, everybody has become aware of this disease. It's possible that the disease may have been circulating for some time, but people didn't diagnose it, maybe confused it with chickenpox, etc. And it is also believed that these cases which have come into the limelight in the past 2 to 3 months, it's not that these have occurred in 2 to 3 months. It's believed that these cases were going on since the past 2 to 3 years, but because it was mainly in men who had sex with men, it was thought that it is a sexually transmitted disease and it was not reported. So it's not that it has come upon us suddenly. It was there, but now it is being diagnosed. And if you look at the current cases of monkeypox, you find that the maximum cases, as I said, is in North America and in Western Europe. And of course, there are some cases in South America, Mexico, Australia as well. And this is actually a very interesting paper which was published recently in NEJM, and which they described the characteristics of 528 monkeypox infections. And if you see, 527 were men and only one was a woman. And there were no children. The age range was 18 to 68 years, and 98% of the patients were actually men gay or bisexual men. 75% were white and 41% had HIV infection. So basically, it was, like what HIV was to begin with. In the early 1980s, cases of HIV were first seen in the homosexuals in San Francisco and Western United States. So right now, at least the current outbreak seems to be more in MSM. And however, most of these patients who were HIV infected were all on antiretroviral therapy, and they had undetectable viral load, so didn't have severe disease. And what is also interesting is that there was no history of foreign travel in 72%, and there were a lot of other sexually transmitted infections like syphilis, gonorrhea in these patients. So basically, this outbreak, at least as of now, seems to be through, high-risk sexual activity. And what was also important was that in this outbreak, in some patients where they analyzed the seminal fluid, they found that the virus was present in the seminal fluid. At least the DNA was present, but we don't know whether this virus could be cultured from the seminal fluid or not. 9% of these patients were hospitalized. 9% had received previous smallpox vaccine as well. And only 13% were hospitalized, but no deaths were reported in any of these patients. So it seems that as of now, monkeypox outside Africa does not appear to be a particularly fatal disease. And why has this outbreak happened? And as I told you that right for the past 10 to 15 years, people have been sounding the alert about monkeypox, but nobody has taken cognizance. So I think the number of cases kept on increasing in Africa. Then there was restriction of the COVID-19. After the restrictions were lifted, there was a lot of international travel. There were people who indulged in high-risk sexual activity, and that is why this outbreak has happened. I think what we as clinicians are mostly interested is the clinical feature of the disease, because we want to know if we are seeing how to recognize a case of monkeypox. So the incubation period of monkeypox is usually between, let's say 14 to 21 days. And there is initially a prodromal phase. And this prodromal phase is characterized by fever, body ache, fatigue, headache, sore throat. So it is almost like any other viral illness. But what is the hallmark of monkeypox, which differentiates it from many other infections, is lymphadenopathy. So these patients get either cervical, axillary, or inguinal adenopathy, depending on where the lesions are present. And this prodromal phase can last from 1 to 4 days. Now the rash, and I will show you pictures of the rash in a minute. But first of all, the rash may involve the mucous membrane. You may have lesions on the tongue or on the genitalia. Now the rash first appears on the face, hands and legs, and then spreads inward. And this is very important to note, because in chickenpox, the spread is opposite. You have first the lesions which appear on the trunk, and then they spread to the hands and legs. The private parts are also involved, and the number of lesions can actually vary from 1 to 500. So you can have people like, for example, in that study published in NEJM that I talked to you about, they were about 10% of the patients, they just had one lesion in the genital area. And there are people who can have many, many lesions, like the picture of an African woman I showed you in the title slide, who had hundreds of lesions of monkeypox. Now, the lesions, they pass on through a macular, papular, vesicular, and then pustular phase. And what is also important is that usually in monkeypox, it is the same kind of lesion which is present all over the body. Whereas in chickenpox, you can have a patient who has lesions in multiple stages of development. So you can have papular lesions and you can have vesicular lesions. Whereas in monkeypox, it is the same type of lesion which is present. And the lesions are quite painful to begin with. And then they become itchy when they become crusted, and the duration of illness is quite protracted. It is about 2 to 4 weeks. And that is why, these crusts are also infectious. So which is very different from from chickenpox, because once we say that the lesions have dried, then the person is not infectious. But here, the crusts are also infectious. And unless the crusts and the scabs fall off, the person has to remain isolated. And another important thing is that the lesions heal with scarring, unlike chickenpox where they don't heal with scarring. So this is just some pictures I borrowed from the internet about how the lesions appear. So this is like a vesicle, then it becomes a pustule, and then it becomes umbilicated pustule, which is again quite characteristic. Here it resembles molluscum contagiosum, and then it becomes ulcerated, then it dries, and then it forms a scab. So if you look at the lesions now, these are again pictures from the internet. And one thing which is very characteristic of monkeypox is involvement of the palms and soles, which is not seen in chickenpox. Now here, if you look at these lesions, they can actually be confused with chickenpox, because here you can, and in fact, what they found in this current outbreak, which was reported in NEJM, that they found people who had lesions in multiple stages of development also. So there you can actually confuse them with chickenpox. And here you actually see a patient who had cervical adenopathy as well. So these are some of the characteristics of the rash. Now, complications are either secondary skin infections, maybe which can happen in 15 to 20% of the patients. Encephalitis can happen, pneumonia can happen, and another important feature is ocular complication, involvement of the cornea, which can lead to blindness. The patient can have scars. And in pregnant women, if they get monkeypox, then there is transmission to the fetus, which can lead to abortion, and even it can lead to stillbirth. And there was one case report from Zaire where when the woman aborted and the fetus was retrieved, there were skin lesions of monkeypox on the fetus skin as well. Now, complications are more in children. So that is why we as pediatricians need to be more aware, because in COVID-19, actually, we were quite relaxed because we were more scared of our own selves being infected or our parents, etc., getting infected, and children actually sailed through. But monkeypox is a disease which can be particularly severe in children. Pregnancy is another risk factor, immunocompromised people, and those who have not received the smallpox vaccine. These are all risk factors for complications. Now, how do you diagnose monkeypox? Now, of course, there are various methods like viral isolation, electron microscopy, immunohistochemistry, but these are not really available. So what is most often available, though still not commercially, is molecular diagnosis. That is RT-PCR from skin lesions, nasopharyngeal swab, blood, and urine. And you can actually demonstrate the virus in all these areas. And you have two types of PCR. One is the genus-specific PCR and the species-specific PCR. Of course, serologic diagnosis is also available by doing ELISAs, IgG and IgM, but these are not specific for monkeypox. They can be positive even in a patient, like for example, the IgG ELISA can be positive even in a patient who has received smallpox vaccine. There is a rapid detection test also available, which can detect it in skin lesions. It's like the rapid antigen test which we used for COVID-19. So if you look at the internet, you have the government guidelines, which have released comprehensive guidelines for diagnosis and management of monkeypox. And they have also release guidelines about where the diagnosis can be done and what is the method of collection and storage of the samples. So if you have suspected case of monkeypox, you can get in touch with the National Institute of Virology, Pune, who can help you with the diagnosis. Now, the most important differential diagnosis is basically one is chickenpox. Now, how do you differentiate between chickenpox and monkeypox? I have told you many things earlier, but some of the important points I'm going to repeat. First, in chickenpox, the prodromal period is short. So you have maybe a short prodrome of about 1 day, after which you get lesions. Whereas in monkeypox, your prodromal period is longer. Then you do not have any lymphadenopathy in chickenpox, unlike monkeypox. And also the lesions in chickenpox first appear on the trunk and then spread outwards. Whereas in monkeypox, they first appear on the hands and legs and the face and then spread inwards. Also, in chickenpox, you don't generally have involvement of the palms and soles. But still, it may sometimes be a little difficult to differentiate between chickenpox and monkeypox. And there are some studies which have shown that many people who were initially in Africa diagnosed as monkeypox were actually chickenpox and vice versa. Again, we are now seeing a lot of cases of hand-foot-mouth disease in children, and that is also an important differential because here also you can see vesicular lesions on the palms and soles. Insect bites, molluscum contagiosum, impetigo, secondary syphilis are some of the other important differentials. Now, what can we do about treatment? So basically, like any other viral illness, the treatment is supportive and symptomatic. So you keep these patients comfortable, you give them fluids because they may not be able to drink because of oral lesions, and these lesions are quite painful. Antipyretics, analgesia, etc. And what about antivirals? Now, they have not, cidofovir is one broad spectrum antiviral, like for DNA viruses. You know that it is commonly used for CMV, etc., but it is very nephrotoxic. There is another derivative of cidofovir, which is called as brincidofovir, which is less nephrotoxic, but there were some people in the UK treated with this and they didn't see any difference. But what is actually a promising antiviral is this drug called tecorivimat. Now, this is actually a drug which was specifically developed for smallpox, and it acts by preventing cellular release of the virus, and it has been shown to be effective in animal models. And it is approved in the USA and Europe, and basically it was developed by the US government because they were worried about a bioterrorism attack with the smallpox virus. So they have stockpiled about 2 million doses of this tecorivimat. It is an oral drug. It can be used in children above the weight of 13 kgs, and it is safe for pregnant women. There have been few cases in the current outbreak who have been treated with this drug. There was one patient who had severe epiglottitis who was treated with this drug, and that patient improved. Unfortunately, we don't have access to this drug in India. Vaccinia immunoglobulin is another modality which is obtained from the serum of people who have been vaccinated for smallpox, and it is used for treatment of progressive smallpox following vaccination. So you know earlier that when the smallpox vaccines were given, because it was a live virus vaccination, there were some people who would get progressive smallpox, and those were the kind of people who were given this immunoglobulin to halt the progression of the disease. But now it is also available, I mean, in research setups or with the US government, etc. And it may be used in immunocompromised people along with antivirals. And actually, it can also be used as post-exposure prophylaxis in immunocompromised people. What about prevention? So smallpox vaccine gives 85% protection against monkeypox. So we don't have any vaccine for monkeypox, but we still have vaccines against smallpox, which have actually been maintained in the world because, again, for the same reason, if there was a bioterrorism attack, because we know that there are certain labs in the US and Russia which have smallpox virus there. So that is why these vaccines are still being made. Now, what are the current recommendations for vaccination? It is not a vaccine for mass administration, but it is recommended for high-risk population, for healthcare workers, and also for post-exposure prophylaxis within 4 days to 2 weeks of exposure. Now, there are various types of vaccines available. The first is the ACAM 2000, which was the live vaccinia virus, which is the same as the smallpox vaccine. Now, this was like this given in the same way the smallpox vaccine was given by pricking the skin surface, but it is a replicating virus vaccine, and it can and it is not recommended for the immunocompromised pregnant women, etc. And it is a less safe vaccine. And now you have modified vaccines which are available, which are being made by some companies, and these are like modified vaccinia Ankara. And the advantage of this vaccine is that it is less, it does not have that much replication potential, and it is given subcutaneously 2 doses 4 weeks apart. And there is no lesion at the inoculation site, and it is safe for immunocompromised people. And this vaccine is available and it is approved in USA, Canada, Europe, and some of the people who are at high risk or some of the people who have been exposed to cases of monkeypox are being given this vaccine. There is another modified vaccine available in Japan, which is also safer than the original vaccine. So, in fact, I was reading in the newspapers that the government has again requested certain companies to start manufacturing the monkeypox vaccine as well. So we don't know, because if monkeypox goes the bad way, if we see the epidemic spilling over in the general population, we might have these vaccines being produced in our country as well. Now, what is about infection prevention and control? Now, remember, this virus is not really spread by small droplets or small droplet nuclei. So you don't need to isolate these people in negative pressure rooms, etc. You can put these people in single rooms with a bathroom at home or in hospital, and you follow standard precautions. You have to isolate these people for as long as 3 to 4 weeks until all the scabs have fallen off. And if the healthcare worker is going into the rooms of these patients with monkeypox, they have to wear a mask, gown, cap, and of course, etc. And even the people who have monkeypox should basically have their hands and legs covered, because otherwise the virus can aerosolize into the air. And if the scabs fall off in the environment, then they can actually also infect other people. And therefore, when you are handling the laundry and the clothes of these people, you have to be careful. Like we used to say that when you are actually handling the laundry of COVID patients, you need not worry, because the virus would get inactivated on surfaces very fast. But in cases of monkeypox, it can actually it can remain on the surfaces for a long time. So remember that DNA viruses are always more hardy than RNA viruses. And that is why we know that hepatitis B, which is again another DNA virus, can get transmitted very easily. And also these pox viruses, etc., can get transmitted easily, and chickenpox, etc., because of this property of survival in the environment. So I think with that, I would like to stop by saying that monkeypox may be the next pandemic. I don't think it is going to be as severe as COVID-19, because basically the virus is not as transmissible. But while as of now, the outbreak outside Africa is in men who have sex with men, it may spill into the general population, because you can have heterosexual spread, and then from families may get infected and children may get infected. Therefore, at this point in time, it is important to be aware of the disease, be aware of the characteristics of the disease, and how to differentiate it from other exanthematous illnesses like chickenpox, etc. And if you have a suspected case, then you must notify it urgently to the health authorities, and of course, we may be looking at immunization at some point in time. I think with that, I would like to stop my presentation and take questions if there are any.
Thank you, Dr. Singhal. Thank you so much, first of all, for removing a lot of fears from the disease. I think in every clinic, patients are coming that is it monkeypox, any child with fever and rash, to our pediatricians. So that fear is removed, that this is unlikely to get pandemic proportions, as the infectivity is quite less and with close contact. And because it is there for several years, gradually, so it is with very little chance that it will go to pandemic proportion. Still, because the WHO had declared with hesitancy the pandemic proportion of this COVID virus, and now it has declared this one pandemic, this global emergency. So people are more scared. So one question from my side, then I will hand over to Dr. Rastogi. Madam, you have said that in most of the cases, almost 100% are in men in one series. How about children, gender ratio in children? Thank you.
So far, the cases, there has been only one child from Netherlands who has been reported. And this child was, I think, 10 years old. And there was a history of travel to Turkey. And then he came back with these lesions. And he recovered. And they could not find where he got the infection from, because there was no family member who was affected. And there was also no history of sexual abuse. I mean, the child was worked up quite well. So I think so that actually makes you feel that you might start seeing cases in children, because at some point in time, but when that is going to happen, we don't know. In Africa, it is common in children. Like, for example, in the Zaire and Nigeria, etc., you have cases in children as well. Because there, the road, the children may get infected from the animals, they may get infected from their family members. But in this current outbreak, as of now, I think I could come across just one reported case of a child.
Thank you, madam. Amit.
Thank you, ma'am. As usual, you are the fabulous and the presentation is lucid. So previously, जो मैंने बोला था कि you are the most south face in during COVID. I think COVID से भी ज़्यादा आपको ही ढूंढा गया मैम उस समय. So there is some question in the chat, and Dr. Ashish Viswas has asked, is there any data on cross protection by the live vaccine?
Sorry?
Is there any data on cross protection by live vaccine? Dr. Ashish Viswas has asked.
So cross protection by live vaccine, meaning, so chickenpox vaccine will not give any protection against monkeypox, but the smallpox vaccine will give protection against monkeypox. Yes.
That's what
these vaccines have really not been validated, because they say that because historically we know that people who got smallpox vaccine didn't get so much of monkeypox as people who didn't get the vaccine. That is why these vaccines are being used currently. But we don't really have a study which says that it will protect people. But because you don't have anything else, you are using these.
I think Dr. Ashish Viswas has got his answer. And Dr. Nirmala Joshi has asked, are these antiviral available in India? If yes, what is their brand name and what is the cost?
So I think only Cidofovir is available in India. It is being marketed by MCure. And it is I think very expensive, some 40,000 per vial or something. But we don't even know whether Cidofovir works. So Ticorivimat is not yet available in India. It's not available in India. It is marketed in other countries by the name of POX, but it is not available in India. And we must understand that most people who get monkeypox will not need antiviral therapy, because, it is a self-limiting disease. We saw that of these 18,000 patients, not a single person died outside Africa. But so most people will not need the antiviral. I think people who will need antivirals are those who are either immunocompromised or pregnant women. They may need antivirals. So I guess if the number of cases increase, then I guess probably, we might have these antivirals coming into India also. But as of now, they are not available.
Dr. Ashish Roy once again asked another question. Are there any efforts by the government of India for procurement of smallpox vaccine maintained by USA or USR for vaccination of high-risk contact?
Not as of now. I mean, I read that they are requesting companies to look into monkeypox vaccine, but they have not yet asked for this, because so far it doesn't. I mean, the government has been pretty quick. I mean, they've laid out guidelines. They have established a network of labs. They have educated people. All that has happened. But for surveillance, they have done this, but not so far about vaccination. Because so far the cases in India don't seem to be that many. Because, 4-5 days ago, we heard about the 4th case. Now it's been 5-6 days and we don't have any more information about, any other case being diagnosed. So I guess they will swing into action once, more cases happen.
Dr. Shravan has asked, how do we differentiate from HFMD? Early presentation is the same.
Yeah, I think HFMDs, again, because here, the current epidemic of monkeypox that we are talking about is mainly in adults. and HFMD is mainly a disease in children. So that is one important feature. The second point is that if you look at the rash is very sharply, it's either in the palms, the knees, the buttocks, or the soles. Whereas in monkeypox, it seems to be more generalized. You normally in HFMD, you don't see many lesions on the face. You find the lesions mainly in the oral cavity. So I think the age, I think, is a very important differentiating factor as far as HFMD and monkeypox is concerned. I think our main challenge will be with chickenpox.
Okay. So Dr. Savan, once again, he has asked, why did we not get spread earlier? It has been there for years. People have been traveling to Africa for years. So
yeah, so I think it happens, when your cases exceed a certain number, then the chain of transmission gets set off. So as I said that the cases were gradually increasing in Africa. So once their number reached a specific threshold, that is the time when it kind of, broke through. Now, it's interesting to know about HIV. So HIV virus was first identified, I think, in 1984. But when they went and studied the sera, the blood, they found that the HIV virus was detected in the serum of a patient in Africa, which was collected in 1959. So it means that the virus has been there for a few decades, but only once the numbers increase beyond a certain threshold that they start getting attention and then they start getting diagnosed. So I think it has to do with the basic case reproduction rate, that once you reach beyond that, then, you start picking it up. In fact, if you scan the newspapers today, it said that, in monkeypox may have been there in India for a long time and we are not detecting it because the strain is different.
There's another question. I think this is or you already answered this, that Dr. Neetu Sinha has asked, should we start smallpox vaccination in the high risk group, like children, immunocompromised patient for prevention?
Definitely not at this point in time, because we must understand that, you start vaccination when you have certain number of cases in the population, and the vaccine itself has side effects. In fact, progressive vaccinia infection is well described as a side effect of smallpox vaccine. But at that time, that risk was accepted because smallpox was causing more deaths. Here you have a disease which is, barely there. And also, it's not very fatal. So you wouldn't start the vaccination for this at this point in time. And also, we must understand that the way the virus is transmitted, it is not going to be an explosive increase in cases like COVID. Because, COVID, though, it just spread like wildfire. Now, if you look at monkeypox and how it gets transmitted by close contact, I'm sure we'll have enough lead time before, we start seeing an outbreak, etc. So I don't think there is any reason to even think about vaccination at this point in time.
Dr. Sanjay Niranjan has asked, what new name is being considered in place of monkey?
Yeah, see, the WHO is always doing these silly things. So they said that they didn't want to, stigmatize Wuhan virus. That is why they called it COVID-19. Because earlier, if you said it was called Middle East respiratory virus, MERS. But they said we must move away from stigmatization. So they didn't want China. In fact, when the variants were being named, you had Alpha, Beta, Gamma, Delta. And then there was some Z variant would come, and they said we won't call it Z because otherwise the president of China will get stigmatized. So now they're thinking that the monkeys will get stigmatized. And also they feel that monkeys may be unnecessarily killed because, remember when that bird flu came, people started killing chickens. They stopped eating chickens thinking that, it is coming from them. So maybe because they didn't want these monkeys to be unnecessarily punished, that's why they want to change the name to something else.
So Dr. Ashish, once again, he is asking regarding that case in New Delhi who had no travel history. What are your view on his source of infection?
I don't know, many details are not there, but when I did a search, I found that this guy had attended some bachelor's party in Shimla a week or two before. So I guess that, it must have been, some high risk kind of intimate activity which must have led to the infection. Because though he didn't have a travel abroad. So I think we will have an increase in number of cases for sure, because we have the only problem is that they may not come to medical attention because of the stigma attached with it. Because the moment somebody is now getting reported with monkeypox, they will start wondering what is the sexual orientation of that person. And WHO is very careful about that as well, that, we should not sideline, we should not discriminate against this community. So people, even if now these 3 poor people of Kerala who's got monkeypox, I'm sure questions would be raised about their, sexual orientation, I guess. Yeah, yeah.
Dr. Shravan has asked, how bad is the scarring?
I saw some pictures, so it can be quite bad. And if you know, I don't know, I can see in my mother's face when she had smallpox as a child, you can still see some of the scars.
Yeah, definitely.
So,
very bad.
And in fact, it has been described in Africa, like some people who got severe monkeypox, their entire skin got sloughed off, and they had a lot of scarring. So compared to chickenpox, definitely scarring is an issue with monkeypox. So even though it may not be a fatal disease, but if people get a lot of lesions on their face, then I think it may not look good later. So that is a concern, yes. So scarring is a problem.
Dr. Ashish, once again, regarding the 4 cases detected in India, what were the clades response? Oh, that has been answered already. Clades 2 or E2, no?
Sorry, I didn't understand your question.
Regarding the 4 cases detected in India, what were the clades responsible? He's asking about clade 1 or clade 2.
Yeah, so I read from the CSIR, they said that it was a lineage A1. So this clade 2 or clade 3, which is responsible for the current outbreak, they are also calling different lineages. So the one which is in Europe, they have called it lineage B1, whereas I think in India it was lineage A2. So they are a little different. So they have all closer to the clade 2 virus of Nigeria, and that is why probably the severity is less and there have not been many fatalities. The Nigerian outbreak, which happened in 2018 to 2019, there were deaths in that outbreak. I think there were 180 people who had the infection, and I think 10 people died. So it was not like, I think in Africa, the fatality would be more because of access to care. And even if these people would get secondary infections, they wouldn't be treated properly. So there were a few children who died in that Nigerian outbreak.
Dr. Sandhya, she has asked, can it be underreported because of its differential chickenpox being benign and not usually work up in first visit?
Yeah, that is why I said that it's possible that the disease may be underreported. One, because people may not disclose it. And in that study, which I talked about from NEJM, there were 10% people who just had one lesion, and that too in the genitalia. So, if people even have it, they will probably think it is some STD, some herpes or whatever, God knows, and then they will not report it. So that is one reason. And second, it may look like chickenpox, so you may just not think. But I think after some time in chickenpox, the rash actually subsides in a week. So initially, people may think of it as chickenpox, but maybe if the rash continues for 2 to 3 weeks, and now I think there is a lot of awareness also. So I think, but clearly the number of reported cases will be fewer than what is actually happening.
The question finished. एक last question मेरी तरफ से ये है, ma'am, what is the percentage of lymphadenopathy which we see in the monkeypox?
I think it is about